Respected President, Madurai ASA, the distinguished guests, Dr. Misra. I don't know whether Dr. Ranganathan has come. Yes, he is a very close friend of mine, so I wanted him to see. In fact, I am extremely happy to be here. I am grateful to the office bearers of the Madurai ISA branch for inviting me to give a lecture with a target audience of postgraduates. And they gave me the option to choose my subject, the topic. Though I have a lot of topics to be spoken to the postgraduates, I have chosen this topic, spinal hypotension, the applied physiology and clinical management. For the very simple reason, there are a lot of misconceptions in the management of spinal itself. Before going to that subject itself, I would like to, because there are a lot of new postgraduates who have entered into this specialty, I would like to make one thing very clear to them. There is a basic difference between a general anesthesia and a regional anesthesia. In general anesthesia, we are making a patient either unconscious or sleeping or whatever it is. And to achieve the triad of anesthesia, we have to use at least 6 drugs. And we have to reverse all those drugs. Whereas in regional anesthesia, there is only one single drug. That is a local anesthetic drug. And you don't need to reverse that, it will spontaneously get reversed. That is the biggest advantage of a regional technique. And so spinal is the most. Now, before going to the spinal anesthesia itself, there are innumerable misconceptions about the spinal anesthesia. And many of these misconceptions, spinal is very safe, spinal is very unsafe because it causes hypotension invariably. GA is safer than spinal, and spinal anesthesia many a times causes cardiac arrest. All these are misconceptions. It is not absolutely true. So we have to keep it in mind before going to a spinal and the management of spinal hypotension. At this point of time, I would like to recall the statement made by Sir Robert McIntosh. It is not the drug that is dangerous, but the man who administers it is. And so also there is no technique in this world which is absolutely safe, and a technique is safe because it is properly employed. So we have to see that any technique must be employed in the proper way so that it is employed safely. The spinal anesthesia has got some facts which you have to remember. It is the most commonly used regional techniques available for human beings all over the world. And it is technically very easy to give it. And so the technical easiness, these two factors make this user to develop a false sense of security, which means they feel that everything is fine by giving a spinal. They feel that they tell the surgeon that I have given a spinal, sir, everything is stable. You go ahead with the surgery, I am going for a coffee. And this attitude at cost, it has resulted in complications. And please remember, there is a major difference between a complication and a problem. A problem is a sequence of a normal procedure. Hypotension in spinal is a normal sequence. We expect it, and if it occurs, we are going to manage that. It is not that we try to make it as a complication. We will never call it as a complication. But exactly, a complication is defined as a outcome of a mismanaged technique. For example, I try to give an epidural. In that process, I overshoot the needle, and ultimately I inject a very big volume of local anesthetic. Total spinal is caused, and the patient goes in for a cardiorespiratory arrest. It is a complication. Their 2 hands are not sufficient. You need more hands, more sophistications, more equipments, more drugs, and all that. It is tackled. So spinal hypotension is a problem which can be managed, whereas a total spinal is a complication which has to be tackled. So that much difference you must make it. So the spinal never say that spinal hypotension is a complication. It is never a complication. It's a sequence of a normal procedure. And then it is statistically, it has been proved that most commonly mismanaged technique among the regional technique is the spinal anesthesia, because it is very commonly given. Similarly, frequent mortalities are associated with that. Now coming to the spinal anesthesia is only for the sake of postgraduates. We are injecting a hyperbaric solution in the subarachnoid space where the nerve roots are lying free. And so the drug has to act mainly on the nerve roots. And for the sake of completion, all myelinated nerve roots, what is the mode of action? It is causing membrane stabilization, depolarization, repolarization, and this waveform is going, and that is how it is conducted. When you apply the local anesthetic in particular point of a nerve, and that membrane gets stabilized, no ionic exchange occurs at that point, so no conduction of possible beyond that point. And the nodes of Ranvier, the myelinated fibers, nodes of Ranvier will be blocked, and minimum 3 nodes have to be, it's a microscopic length, point, but a microscopic 3 nodes of Ranvier have to be blocked. And another important factor you have to remember is the A delta fibers, which carry the pain and temperature, needs 50% less concentration than what is required for a gamma, which is transmitting the motor impulses. And when you come to the sympathetic blockade, sympathetic nerve requires less than 20% of that required for the A gamma fiber. So you can remember a sympathetic blockade can be very easily caused by a very low concentration of local anesthetic. That has to be remembered. That's one thing is very, very vital. And then coming to the order of blockade, it comes in this order. As soon as you put this local analgesic, the first nerve to be blocked is the sympathetic. Preganglionic sympathetic fibers will be blocked, and immediately hypotension will be caused. And then the temperature, among the temperature, the cold will be earlier, and the warmth will be blocked a little later. Then the pain and the pinprick and pain, among that the pain is blocked earlier. So that what happens is, when you try to test the level of blockade with a pinprick, patient would have gone for a say pain loss, but the pinprick will be felt by the patient. So if you want to check the level, it is not using a pinprick, it is only with a cotton swab you try to do that. That is one important point you have to remember. Then touch. Then after the pain is lost, the touch will be blocked. So if a hasty surgeon is trying to paint, and before this touch is lost, the patient will be complaining, I am feeling everything, sir, I am going to feel the pain. And that is a problem, that also we have to remember. And then the deep pressure, motor fibers, and finally vibration. And the recovery occurs in the very reverse process, the proprioception, that is the our position sense will recover first, then motor, then the deep pressure, then the touch and all that. But fortunately, for reasons which have not been well explained, the sympathetic blockade recovers before the sensory blockade. That is very, 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 very important clinically. So vascular tone recovers early, and the hypotension recovers. The vascular tone, the hypotension gets reversed earlier, and that is a clinically very significant point which we cannot forget. I will talk about that a little later. So this is for the sake of completion for the postgraduates. I have targeted the postgraduate. This lecture is mainly targeted for the postgraduates. If your surgeon is asking, you are given I will not tell that you are given. I have given a spinal in the morning, and my surgeon is asking me in the afternoon, can I make the patient walk? I must be able to tell a very clear-cut answer for him. I said, you make him walk in the evening. That is not the answer. I must examine the patient and tell him that the whole thing has been, what spinal I had given, all the things have been reversed, you can make the patient walk. We have blocked to 4 modalities. One is the autonomic, then the second one is the sensory, third one is the motor, the final is the proprioception, that is the position sense. If all the 4 have been recovered well, the patient can walk. How are you going to test that? If the patient is not having a hypotension for 3 complete hours before you see the patient, the sympathetics have been completely recovered, and the sensation is present in the around the anus, skin around the anus. It means that coccygeal nerve, that the last nerve in the spinal, among the spinal roots, and that has been completely recovered. So this patient has recovered completely from the sensory blockade. And the next one is motor. How are you going to say that? Make a plantar reflex elicited. There must be a very strong extensor plantar. It assures that your muscles have recovered fully. And finally, proprioception. Of course, proprioception will be the first one to recover, but anyway we have to check that. Close the eyes of the patient and make the big toe move this way or that way and ask him to tell where exactly the position is. And if that is there, you can ask the patient to walk. There will be no problem at all. Even if the patient is drowsy because of the sedation, he can walk definitely with the help of somebody. Now coming to the spinal hypotension, it is a very, very simple phenomena. There is a disparity between the volume and the capacity. And normally in our body 5 liters of blood is circulating within the capacity of 5 liters space and with a little amount of modulation. But now I have given a spinal, I have made that capacity as 6 liters and the volume is only 5 liters. It is not sufficient to fill the system and the cardiac output suffers because of that and hypotension comes. That is a very, very simple explanation for that. We will explain it a little more detail. And so every patient differently behaves for that hypotension. The disparity will be different in every patient. So every patient has to be individually assessed for management. Never try to set a protocol. The protocols do not help. If you try to set a protocol for managing a spinal hypotension, you are going to fail sometime and you will lose some of the patients, at least 1 or 2 patients in some random way. And then we have to know about the applied physiology before going into management. And in that there are two main things we have to concentrate. The one is now applied physiology. Because I am more worried the postgraduates must be properly conceiving what I tell. Applied physiology, there are 2 things we have to bother. One is the effects of spinal on the circulatory system. The next one is the compensations available. So if you can understand that properly, there will be no problem at all in managing the spinal hypotension at all. Now effects on circulation, what happens is the preganglionic sympathetic fibers are blocked and thereby systemic vascular resistance is enormously reduced. The arterioles dilate and the volume of the capacity which is available has been increased. And so the vascular capacity becomes larger than the volume which is circulating. And so and not only that, the venous system will be blocked. And the venous system, mainly the larger veins in the lower limb and the splanchnic bed, they are called as a capacitance vessel. They will be having the venous pooling, which will result in the reduction in the venous return to the heart, and then there will be a reduction in the cardiac output, and finally it will result in hypotension. This is the mechanism by which it is occurring. So we have to remember that when you see a patient with dehydration, hypovolemia for some reason, you have to treat the dehydration or hypovolemia before taking up the patient for spinal. Otherwise, there will be a severe effect, like all these effects will be manifested very badly and the patient may go for a cardiovascular collapse. Now the compensations available, if you can understand these compensations available, we will never make a mistake. So we will try to, the immediate response comes by the sympathetic activity to combat the problems caused by this spinal hypotension. So the sympathetic system immediately comes to protect it, and the unblocked area where you are given a spinal blockade lower down and the upper part of the body is free. So there will be a sympathetic activity which constricts a vascular tree to make a compensation for the increased vascular space. And if there will be a vasoconstriction in the upper part of the body. Unfortunately, the lower part of the body has more than two-thirds of our vasculature when compared to the upper part, which has got about one-third. And in spite of that, there will be a good compensation caused by the vasoconstriction. And then the tachycardia and the increased force of contraction caused by the sympathetics will be definitely going to try to increase the cardiac output and try to compensate that. This is the immediate compensation, and that will be invariably very good in a normal healthy individual. There is nothing to worry about that at all. And after that, the next compensations come from these hormones, and the hormones are mainly the renin, angiotensin, aldosterone mechanism. The renin is released from the juxtaglomerular apparatus in the afferent arteriole for the glomerulus, and that is going to act on the angiotensin 1 in the circulation, which is generated from the liver. Of course, this angiotensin will be renin converts it to angiotensin 1, which is an inactive form, and the ACE, angiotensin converting enzyme, converts it to angiotensin 2, which is a very potent vasoconstrictor, and that comes into play immediately. Immediately after the sympathetic, the next compensation comes like that. So you must know that the nature is too great, it is going to protect the patients. If only we try to, very adamantly try to do harm to the patient, normally no harm can be done for the patient. So you can understand that this angiotensin, now the angiotensin 2 is a vasoconstrictor that is going to act on the adrenal cortex. The adrenal cortex, the zona glomerulosa secretes the mineralocorticoid, which will be released in the circulation, which acts on the distal convoluted tubules and the collecting tubules, there where it is trying to restrict the fluid loss by reabsorption of the sodium and water, so that the volume is conserved. And then ADH, please remember, ADH is one of the best mechanisms where our volume is protected. ADH is a posterior pituitary hormone. As we have these baroreceptors in the aortic sinus and carotid sinus, there are baroreceptors in the right atrium, inferior vena cava, and the superior vena cava. They are not called as baroreceptors. They are actually baroreceptors, but they are called as volume sensors, because they are going to because the stretch is caused, and the volume sensed by this will be, when the volume is reduced, it sends afferent impulses to the pituitary and the ADH is secreted. ADH is called otherwise by vasopressin. It is available commercially now in our country, and it is again a very potent vasoconstrictor, and that is going to act on the vasculature to cause vasoconstriction to compensate that. Not only that, it suppresses the diuresis by so that it conserves the volume of the blood, so the circulating volume will be maintained. If we can understand this very well, we will not make any mistakes. At this point, I would like to add one thing. Similarly, when your volume is increased, if you are giving a very large volume of fluid by rapid infusion, unknowingly or knowingly, what will happen is the volume sensors will be stretched so much, and the afferent impulses go to the pituitary. The pituitary suppresses the ADH, and so what will happen will that there will be an enormous diuresis to send out the extra volume which has come into the system. So you have to remember that this is a very beautiful system. I have demonstrated this diuresis because it takes hardly 5 minutes. Unless you see that, it is hard to believe it. I have demonstrated that in emergency cases when there is an rapid infusion given, the rate of infusion and the catheter, you take the catheter and see the amount of urine secreted. If you compare that, possibly many times what happens is the rate of infusion will be slower and the rate of urine output will be larger. As a result, it will result in dehydrating the patient. So when you want to give a hydrating therapy for hydrating a dehydrated patient, you have to be more careful in the optimizing the rate of flow, otherwise you will cause more diuresis by this ADH mechanism. This again is an information which I would like to give for the postgraduate. It's not for any other senior people around here. Now with the physiological control of our normal BP is, that the cardiac, our blood pressure is maintained by this is again for the postgraduates, please pardon me, the senior people around here. And the cardiac, it is a product of cardiac output and systemic vascular resistance. And when you see the cardiac output, it is a product of the venous return and the stroke volume and the heart rate. If any of these things is reduced, then definitely there will be a reduction in the cardiac output and the hypotension will be caused. The venous return is reduced, there can be hypotension. Stroke volume is reduced, there can be hypotension. Heart rate is reduced, hypotension will be there. So we must maintain this in the optimal range. And the venous return is aided by the gravity from the upper part of the body and the muscle pumps from the lower part of the body, and the thoracic negative pressure draws the blood from the lower limb, and so that the venous return is very beautifully modulated in a normal individual. And then vascular resistance is simply the vasomotor tone caused by the sympathetic system, but it will be definitely aided by the renin, angiotensin, aldosterone mechanism, and also by the ADH. Now this is in the form of chart. but it is not simply that short. I have some very valuable information for the postgraduate. The arterial pressure is the result of the product of cardiac output and peripheral resistance. Okay, that's right. Now this cardiac output is the product of venous return, stroke volume, the heart rate, and the stroke volume is called as it is inotropic effect, and the heart rate is it is a chronotropic effect, and this is controlled by the autonomic nervous system, and the chronotropic and inotropic effect, and the venous return is supported by your gravitational forces, intrathoracic negative pressure, and the blood volume and the muscle pump. And the autonomic system has a support on the peripheral vascular resistance also. And as we have discussed, the renin, angiotensin, aldosterone and ADH definitely help in the hormones help in the peripheral resistance, and that help in the supporting the blood volume also. And I have given some something here, metabolites. Please remember, if a patient is in metabolic acidosis, all the catecholamines will be inactivated in the bloodstream itself, system itself. There are two things. In severe metabolism, two things can happen. One is circulating catecholamines will be inactivated, whether it is endogenous or exogenous, whether you give it or it is secreted by the adrenals. The second thing is there will be a desensitization of the receptor, so that even if a catecholamine reaches the receptor, it is not going to act. So we have to remember that if a patient is having hypotension, you have to check whether the patient's metabolic status is normal. If there is a acidosis, please remember, unless you correct it, the hypotension cannot be corrected. It is not for the spinal hypotension, it is for any hypotension for that matter. When we are coming to the hypotension, spinal hypotension, whenever you see a spinal, whenever you give a spinal, assess the level of sympathetic blockade. And the sympathetic blockade is going to cause, we have discussed that earlier, but anyway, that is going to determine the level of the fall of BP. And the sympathetic blockade is 2 to 3 segments higher than the sensory blockade. Suppose, imagine that I have given a blockade up to T10 level, definitely the sympathetic blockade is somewhere here. There is 3 segments above that, T7. And higher the blockade, you are going to have more of a hypotension. Then the sympathetic system, we have to know very clearly the sympathetic system. It is starting from the thoracic 1 to the L2. That is called as thoracolumbar outflow. The whole body is getting all the ganglion are receiving the preganglionic fibers only through these T1 to L2. That's all, thoracolumbar outflow. And the next thing which you have to remember is the adrenal medulla is a very big sympathetic ganglion, and it receives its preganglionic fibers because the adrenal medulla is the biggest ganglion available, and that is the one which is released in the catecholamines for our day-to-day and the minute-to-minute modulation of our cardiovascular system. And so naturally, adrenal medulla is getting its supply from T8 to L1. And if I am reaching a blockade to T7, definitely the sympathetic supply, the preganglionic supply to the adrenal medulla is lost. So there will be no secretion or very minimal secretions of catecholamines on the adrenal medulla, and it is said the lower part of the body is completely sympathectomized. So you can imagine that the compensations can come only from the upper part of the body, and so that is one major problem. And the cardiac sympathetics come from T1 to T4, and people may imagine, why do you go up to T4, T1? We never go like that. Contrary to the popular belief, very commonly the cardioaccelerator fibers are blocked by giving a spinal, particularly when we give a bigger volume more than 3 ml. When you give more than 3 ml, the ascending of the solutions can occur because of various factors like movements, turbulence and diffusion. and the T1 can be up to T1 can be sympathetics can be blocked and cardiac accelerator fibers can be blocked. When you secure here again, please, the postgraduates, please remember, you can test the dermatomes only up to T5. After that, you will not be able to test the dermatomes because the upper part of the anterior chest wall is being supplied mainly by nerves coming from the cervical plexus. It is not from the intercostals. You know how? We know that the cervical plexus is there and there is a deeper portion and the superficial portion. The superficial portion has got only cutaneous innervation, cutaneous nerves, and there is a transverse branch, ascending branch and a descending branch, and the descending branch is called as a supraclavicular block if you carefully remember your anatomy. And the supraclavicular nerves come like this, and it is going to block up to a level a little lower than the nipples. So up to the level of T4 to T5, the anterior chest wall cutaneous innervation come from the cervical plexus. It is not from that. So if you are trying to assess that, oh no sir, I have reached only a T7 level, not beyond that, it is not correct. It is likely to be wrong. And then below the level of L2, because the thoracolumbar outflow is only up to L2, and below the level of L2 there will not be any hypotension because the sympathetics will not be blocked. But we don't like to give a level like that unless you try to give a saddle. I had noted that saddle. The saddle blocks, I don't know whether anybody had given a true real saddle block. Even if you attempt to give a saddle block, it is very rare that we reach a saddle block. It will be ascending a little higher up, because the L1 level is the inguinal level, L2 level is the medial aspect of the thigh, and so it goes on like that. So we cannot do much of the saddle block can be given for a perineal surgery, but the patient will be moving the limbs. So we don't normally do it. Now what will happen if that cardiac accelerator fibers are blocked? Now the cardiac accelerator fibers are blocked. You must understand that the cardiac function is so beautifully modulated by the sympathetics and parasympathetics. And the sympathetics are always overactive, like many of us. And what happens, it is trying to keep the heart rate very high. And this vagus is the modulator for the heart rate being controlled. And otherwise, most of us, though anesthetists who are working in stress, will be having a heart rate of 100 or 110. And we don't have like that. All of us have only 72. As a matter of fact, my heart rate is less than 70. So this is being controlled only by this vagus. Vagus is the modulator of the heart rate. And so what happens is, when there is no sympathetics available, it takes unopposed activity and the heart rate and contractility will be reduced. And when the heart rate is reduced, immediately, the heart rate may come down to 50 even. When it is coming as 50, we should not keep quiet, because the 50 rate is not sufficient for adequate cardiac output. It is not alone that problem. The problem is that at 50 heart rate, there will be stagnation in the pulmonary vasculature, and the tendency for pulmonary edema is more in those patients. So immediately you have to reverse that bradycardia. How are we going to do that? The only single drug, the beautiful drug, is atropine, and you don't give 0.6 milligram. You have to give a small, because if you give 0.6 milligram, it will jump. The heart rate from 50 will jump to 110 or 100. You don't want 100 at all. We want something around 70 or 80, something like that. So what is that? We do 0.2 milligram give, wait for 1 full minute, so that definitely we know that it is going to act, and then the rate comes up to 60 or 62. If you are not very happy with it, give another 0.2 milligram, it will come to 74 or 80 and stop with that. You don't have to try to do anything more than that. Regarding the contractility, you cannot reverse that with atropine, because you need to stimulate the beta receptors. Beta receptors in the heart, we don't need to do that at all. And the contractility, the minimal reduction in the contractility is not going to cause any problem at all. But people are so much scared. That is one of the reasons why everyone is very happy to give only ephedrine, not anything else, because the ephedrine is a drug which is going to act in the heart, causing both chronotropic and inotropic effect. and so they are happy. All the people are so fond of using say ephedrine. In fact, for a short time, the ephedrine was banned by the Drugs Control Authority because it was misused by the athletes. And at that time, I had very many of anesthetists. If ephedrine is not available, how are you going to give a spinal? We can't give spinal. For your information, my dear friends, my dear young friends, believe me, I had never used say ephedrine at all. I always used mephentermine. For all my patients for 45 years, it is the 46th year I am doing it. I never use it. I don't want to use it for various reasons. I will come to that later. So you remember that. In spinal hypotension, there is no problem in the heart at all. The problem is the disparity between the volume and the capacity, and what you have to do, the proper solution is fill the volume so that you make up the volume. That's all. It is very simple as that. And is whipping the heart to make a higher rate and contraction by stimulating the heart to do extra work for filling the dilated vasculature is not very scientific. So you can avoid that if it is possible. And what is hypotension? Then people say that systolic pressure less than 100, so less than 90, and 20% of the baseline drop, and 30%. All these are figures. These figures do not carry any meaning at all if you are not able to apply it to the concerned patient. So it is ignoring. You can definitely remember that this does not take into consideration the cardiovascular status of the patient and the organ perfusion of the patient, and so we have to more worried about the cardiovascular status and vital organ perfusion, and accordingly we have to decide at what level we have to maintain the BP for that particular individual patient. That is why never set a protocol for managing a hypotension. It is not going to be all right at all. And this is a statement of Wiley. A normal BP, normal value of BP is not everything to, not the only criterion to say everything is very fine with the cardiovascular system. It is not my statement. I always quote it from the book. Vital organ perfusion during hypotension, what we have to worry about, our deep concern must be about the vital organ perfusion, not at the BP level. If the BP is 200, okay, it is not all right. BP is 100, it is not right. As long as you are able to maintain a vital organ perfusion, whatever BP you keep it, if there is a vital organ perfusion going on well, that is what is required for that patient. It is not for us to have a 120 BP. I am very happy, sir, the BP is 120. It is not that. And it is controlled by the autoregulation. Autoregulation is the compensatory mechanisms that ensure adequate perfusion of vital organs in a wide range of arterial pressures. And that arterial pressure is a systolic pressure range. For the coronary it is 60 to 150, the cerebral it is 50 to 180. You have such a wide range of, so within the range there will be absolutely normal perfusion available for the organs. And for the renal there is a disadvantage, the lower level is 80, but on the spinal it comes out down a little 70 or something like that. You need not worry about that. And for the coronary, when there is a tendency for ischemia in coronary arteries, there will be there will accumulation of ADP, adenosine diphosphate, which will be instantly converted into adenosine, which is a strong and potent vasodilator, coronary vasodilator, that improves the perfusion. And here again, there is a quotation from Wiley: hypotension has a benign effect on unless there is a severe tachycardia and the increased pressure across the aortic valve. When there is a tachycardia, the diastolic time is encroached, and the time available for because the perfusion to the coronary occur during diastole, the time available is encroached, and so necessarily diastolic filling will be, coronary filling will be reduced. Next thing is aortic pressure. When there is a big gradient, what happens is the intramural pressure in the ventricle is going to be very, very heavy, and the diastolic pressure is going to be very low, and that is not going to overcome this intramural pressure and perfuse the that is why many of the times we have heard patients, aortic stenosis patients developing sudden death. That is how they die. So we need not worry unless there is and I am very sure we are not going to give any spinal for an aortic stenosis patient. We never do that. Now coming to the cerebral, beautiful, that is 50 to 180. And the cerebral vessels do not have any sympathetic supply at all. They are controlled by their reflex mechanisms. The reflexes can be chemical or mechanical. The chemical is related to the acidity or the alkalinity, and mechanical is the stretch response. And in arterioles dilate, arterioles constrict during hypertension, and so the control of the vascular flow is maintained. In hypotension it dilates, and so that it is well maintained. And it is established beyond doubt. This is a statement from the books. The cerebral perfusion is very well maintained when the mean arterial pressure is 50 millimeters of mercury. You don't need to worry at all that at a 60 systolic pressure the patient will have cerebral perfusion failed. It will never fail. So don't worry about that. The renal, the afferent glomerular artery has a myogenic control, and when there is a stretch, more stretch by a hypertension, it tries to constrict. When there is a less stress by the hypotension, there will be a dilatation. In hypotension, there is very, very minimal reduction in the GFR. Glomerular filtration rate is reduced very minimally. It is less than 10%. In that, it is normal, healthy individuals. It does not do any harm at all. But if a patient is having an impaired renal function, you have to worry, and accordingly you keep a level which is higher than that. This is my statement. I have been giving spinal for the last 46 years. Many thousands, at least many tens of thousands I would have given. I had never used ephedrine, and I have never come across any patients going in for any complication in my spinal, by God's grace, of course. And spinal hypotension will not kill anybody, any patient. It will kill only if you ignore that. I give a spinal, I go ahead, sir, I am going to have a vada and coffee, and then I will come back. By the time you come back, the vada, you will not even digest that. You may be in trembling that the patient would have developed cardiac arrest by that time. You cannot go out. If you give a spinal there in some matter, you have to be there. That's all. That is a message I would like to give all the young postgraduates who are here. If I am happy, if I am convincing you in that way, so much of energy which I am spending now is quite okay. So always remember that when the spinal hypotension will never kill a patient unless it is ignored or mismanaged. The ideal management is you calculate the mean arterial pressure for that particular individual patient and maintain the BP at that level, around that level. If you calculate it is 100, okay, it is okay. If it is 90, it is okay. 120, it is okay. Even if it is a little less than say 90, 86, it is okay. But you don't need to worry, but you must try to do that it is around that level. Now this is again a very, very vital information for the postgraduates. Now the rate of fall has a higher significance than rate of the degree of fall. I will explain this very clearly. I have given a spinal and the patient has developed a hypotension. There is a drop of 40 millimeters of mercury. From 120 it has come down to 80. But it has taken 25 to 30 minutes for the whole drop to occur. So it means it is an insidious fall. And all the compensatory mechanisms come into play, and I am giving an infusion of fluid, and that is also managing things well. And I did not worry at all. But in the contrary, when I give a spinal, I turn back the patient and is settling before everything is settled. I check the BP. The BP has crossed to 60 systolic. It is a catastrophic fall. If I am not doing anything very briskly at that time, I am going to lose that patient. I have to give three things. I have to give a vasopressor immediately. I have to rush in the fluids. I have to give oxygen for the patient. These three things you have to do that. If only you do that, the patient is not going to survive. The patient will go for a cardiac arrest. And it indicates the fall. It is said a fall to a level of less than mean arterial pressure within 5 minutes time is very dangerous. It indicates very poor. It is not very poor. There is no compensation at all available. If only there is no compensation, the patient can crash a BP like that. And this needs aggressive treatment. So far I never used the word treatment. I was using the word management. But here it is a treatment. If you don't do that treatment, the patient will be lost. And insidious hypotension, you don't need to worry. You increase the rate of infusion and administer 10% oxygen by a mask, and the mask I have highlighted. Always use a mask, anesthetic mask with the breathing system, not any other mask, and tight fitting mask, and assess the ventilation, assess the ventilator excursion in the bag, and then give it. And that breaks the vicious cycle, and the further fall of BP is stopped. But acute severe hypotension, we are very much worried. I said, if I am not treating immediately, I am going to lose the patient. You know why? The vital organs, vital centers in the brain, mainly the vasomotor center and the respiratory center, the perfusion to the vital center will be dropped drastically, and the centers suffer hypoxia. And this vasomotor center and respiratory center depression will cause a serious vicious cycle, and the patient will go for a cardiorespiratory arrest. And the opioids may be, the respiratory center may be already depressed by your opioids, and so you have to be more careful about that also. Now, vasomotor center depression, those sympathetics are causing the vascular contractility and all that. The overall control is from the vasomotor center, and once the vasomotor center is lost, the compensatory vasoconstriction which is going to be there in the upper part of the body, which is not blocked, that will be lost, and so that fails. The hypotension is aggravated, the patient goes in for cardiovascular collapse. And the respiratory depression, there will be hypoventilation. When there is a hypoventilation, two things happen. One is the patient will go for hypoxia, it may be mild or moderate or severe. Secondly, because the ventilator excursions are very small, the intrathoracic negative pressure will be less, so that drawing of blood into the thoracic cage will be reduced, and it reduces the venous return and the cardiac output, and the further hypotension will be caused. So please remember, the hypoxia and hypotension and hypoxia, both together form a vicious cycle in perpetuating the hypotension and thus vital center depression. So we have to break that. How are you going to correct it? Now, filling the expanded capacity rapidly by a very rapid infusion of fluids, and using a vasopressor to support the vasculature, and giving 10% oxygen. If the three things are done, definitely it will improve the blood flow to the blood flow and oxygen supply to the vital centers, and the hypoxic depression will be reversed, and the BP will pick up very quickly. And coming to the vasopressor, these are the vasopressors, the ephedrine, the most liked by all the anesthetists in the world. Though I don't use it, I don't like it. The methoxamine is something very similar to noradrenaline, but it is a milder acting drug that is not available in our country. Phenylephrine is 100 microgram, it is not available in our country. And mefentermine is a very soft, beautiful, it cannot have much of action in the heart, it has an action on the peripheral vasculature, and I use this drug 3 to 6 milligram increments. It is incrementally, we never use big doses, it is only small increment. And these vasoactive drugs, dopamine, dobutamine, I have never used at all for any of my spinal patients at all. Believe me, I am not telling any lies. There is no need for me to tell any lies. At this age, there is no need at all to tell lies to my youngsters. So I am here only to tell the truth. Now the preloading, the concept of preloading is a controversial affair. The preloading, again, please remember what I told you about the ADH mechanism. I want to give 1000 ml of fluid as a preloading, and after that will take about half an hour. And after half an hour time, I am going to give a spinal. You know what will happen? The ADH mechanism would have worked, and the patient will be having a urine of 1000 ml in the bladder. When I give a spinal, the patient will be having a 1000 ml of urine, not in the volume, the system, it will be in the bladder, and that will necessitate a catheterization in the postoperative period. And I don't believe in, and not many people believe in that, but some people try to do that. And so the more scientific, it is not universally accepted. And the scientific, physiological and practical approach is, watch the patient. And if there is a hypotension, treat the hypotension. It is very simple as that. Now with this patient, imagine a patient like this. A patient is well sedated but arousable, and he is very well oriented. He is able to tell everything with full orientation. And left alone, he is sleeping. And if he is questioned, he wake him up and ask him, are you comfortable? I am comfortable, sir, there is no problem at all, he says. And when you look at the tongue, it is moist and pink, indicating that the perfusion is very beautifully going on. And the respiration is 14 per minute, and it is adequate. Oxygen saturation is 97. The BP is 80/60, and the pulse is 82, and the volume is very good, full volume pulse. and the urine output is about 0.75 ml per minute. What is wrong in this patient? Is there anything wrong in this patient? Absolutely there is nothing wrong in this patient, because I will tell you, please remember today, if any one of the postgraduates in the middle of the night at 1:30 ask your friend to come and check your BP, it will be 80/60. When you are in the deep sleep, it is only 80/60. None of our people die because during our deep sleep the BP is 80/60. None of them die in the night. If we wake him up, the vasomotor center wakes up, the sympathetics wakes up, the BP comes to 100. It is very simple as that. Everything else is normal. Everything else is absolutely perfect. And the BP is only 80. And the 80 itself is not very low. It is within the range of the, say, auto-regulation range of the organ perfusion. We are not worried about that. And I am reminded of one of my very beautiful postgraduate, very best postgraduate, now he is a professor. When he was doing DA, I asked him to give a spinal. He gave a spinal. After that, today I told that story to Vijayaraman. But I asked him to check the BP. Immediately after that, he said, it is 120/80, sir. Okay. Then I told him, you don't need to, diastolic is not needed, I want the systolic only. After 3 minutes, I asked him, he said, it is 114, sir. After 3 minutes, I asked, it is 100, sir. After 3 minutes, he said, it is 90, sir. And after 3 minutes, he said 80. I asked him, are you worried? No, sir, we can give the fluid fast and wait for some more time. And then after, say, 5 minutes time, I checked, asked him to check, it is 70. I asked him, are you worried? No, what he said? You are here, sir. He transferred the responsibility to me. I said, I definitely would like to give 3 milligrams of mephentermine to bring it up to 90. But I wanted to show him that, do you remember that in the beginning I said that the sympathetics will recover earlier than the sensory blockade? It makes a big dip in the, say, something like about 25 to 30 minutes, and then it recovers, starts recovering. Before the surgery is over, everything will be recovered. And so what happens is, I wanted to show him that it is going to recover. So I said, you don't worry, I'll take the responsibility. After 5 minutes, I asked him to check, it was 80. After 3 minutes, I asked him to check, it was 90. So it was in the recovery phase. Only to demonstrate that I did that. There is nothing wrong in that, because 70 is not going to kill. He was a very robust young man, load man, who was being operated for a herniorrhaphy. If I am convincing you all this, I will be happy. And when there is a hypotension like this, please remember that this sort of a situation never happens in our life. Only anesthetists make this such of a situation of patient when you give a spinal. And the myocardium enjoys this situation. Just imagine that. There is no need to pump blood against the gravitational forces, because the whole the circulation is in the horizontal position. And there is a minimal afterload. There is no resistance to flow at all. The heart is very softly pumping the blood. There is no resistance at all. There is no problem at all to pump the blood. And there is adequate venous return, preload coming to the heart. And in the horizontal position, there is no effect of gravity working on that. So allow the myocardium to enjoy that hypotension, I say. It is something very akin to a small child playing with his things in the cozy, dark corner of the house. As long as the child is healthy, as long as the child is happy with that, you don't need to chase the child out to go and play outside. There is no need at all. Let the child enjoy what it is enjoying. So now the permissible hypotension, what is permissible? It is a systolic pressure within the range of the auto-regulation, where three things are well maintained. One is the heart rate is well maintained, the adequate coronary perfusion is maintained, all vital organs of perfusion are maintained. If all that is there, we are happy. What degree of hypotension requires? This question is, in spite of all this discussion, I am asking this question, and here the books say that the decision is made on the merits of the individual patient. So if you give a spinal, you cannot go out, you have to assess the merit of the patient, and there is nothing else you can do that. And this is a wily statement, but there are very few patients who cannot tolerate a decrease of 25 to 30% of the drop of BP. Now coming to the key points. Please remember these key points. A careful continuous monitoring is the only single major key. This is the master key. If you lose the master key, everything is lost. So always remember that when you give a spinal, there is nothing else you can do. You can only to watch the patient carefully and monitor the patient. And the moderate hypotension does not cause any harm. It is absolutely harmless. And there is a special advantage to the surgeon. There is an advantage of bloodless field, relatively bloodless field. And our main aim in a spinal hypotension is maintain the adequate circulating volume and vital organ perfusion. That's all, nothing other than that. And the rapid fall of BP when it is crashing, always remember that you use a vasopressor, you use a IV fluid, you use 10% oxygen. That is the solution for that. Thank you all very much for the patient listening. Thank you.